I'm going to start the recording.
Hello, everyone. Welcome to the webinar organized by the Women in Health Together for the Future. Um, I am Nigat Hudat, Board Chair of Women in Health Together for the Future. I welcome you all to this webinar. And I would like to give you a brief description, very brief description of about WHTF. We converged as a small group as way back in 1991 as part of the international network. And then in 2019, we are now established as an entity, as an organization registered in South Africa. And, and our office or secretariat is housed in Western Cape University, Department of Community Health Sciences. Um, we have been holding this webinar. This is a monthly webinar, and besides this, we have several. We've had projects ranging from different topics. We invite people. We have members. Our board members are across several regions, and they represent several regions. And we also have other activities also organized by WHTF. So I welcome you all today, and I also urge you to become a member. You can go to our website, womeninhealthtogetherforthefuture.org, and you can register. You have a choice of membership, and depending on the region, according to the World Bank. And then you can also, it's paid membership as well as you have associate membership where you don't have to pay, with limited, of course, benefits for that. But I hope you will join us and contribute to our mission of improving women's health. Now, I won't take much time, and I will invite Judy Lewis, our former board chair, as well as, of course, founding member and a passionate member of WHDF. So it's my pleasure to invite Judy to introduce the our speaker as well as the topic for today's webinar. Thank you, Judy.
Thank you, Nagat. So good morning, good afternoon, good evening, everyone. It's nice to have you on the webinar. It is my pleasure to introduce Dr. Shayna Cunningham, who is my colleague in the Department of Public Health Sciences at the University of Connecticut School of Medicine. Shayna is an associate professor in our department with over 20 years of experience in global and domestic public health. Her research focuses on advancing health equity for structurally disadvantaged people, particularly in women's health and maternal and child health. She's an expert in mixed methods and community-based participatory research, and she really works to develop interventions to improve outcomes of the work that she's involved in. Dr. Cunningham has degrees, a Master of Health Sciences and a PhD in Public Health from Johns Hopkins. She was also on the faculty at Yale University before coming to the University of Connecticut. She has experience working with several global foundations, and so she also knows that side of the work. And her work bridges research, program implementation, and capacity building. I'm happy to say she is a dedicated member of Women in Health Together for the Future and has recently been elected to serve on the board. So we're really happy to have her participation. This morning, she's going to be talking about bladder health, which is, as we all know, many women's health problems that are outside the reproductive health arena are neglected. And that's been demonstrated by many recent reports. Shayna is addressing bladder health, which is probably one of the most neglected topics, and for a variety of reasons. So I think it's really important that we're doing this webinar. We're looking forward to hearing from Dr. Cunningham and having a discussion about how we can broaden the impact of this research and think about it in the context of many countries, because I think women experience a lot of shame around bladder health issues, and that's a big deterrent to addressing the problem. So Shayna, I'm turning it over to you.
Thank you so much. I am really happy to be here this morning to share this work. And let me get my screen. All right. Like I said, I'll be speaking today about the Prevention of Lower Urinary Tract Symptoms Plus Consortium and work that I've been involved in as part of this group over the last 10 years to develop and really advance the field of prevention science as it pertains to bladder health specifically. My goals for this presentation are one, just to raise awareness about bladder health in general. I'll provide an overview of the PLUS Research Consortium, the process that we've been using to develop this new field of science, and share some select findings for studies that we've conducted over the past 10 years. Most people don't think about their bladder health unless they have symptoms that are inhibiting their activities or well-being in some way, and these are some of the symptoms that are commonly experienced on this slide. But the truth is, lower urinary tract symptoms, or LUTs as we often call them, are very prevalent among women, albeit they're not talked much about women or by their providers outside of urology. More than 200 million people worldwide suffer, for example, from urinary incontinence. Or in the United States, the prevalence of overactive bladder is around 16%. Estimates suggest that up to 75% of women who experience urinary incontinence don't seek care, and those that do often wait an average of 6.5 years before they speak to a healthcare provider about their symptoms. There's a common misconception, particularly among women, that it's normal to experience bladder problems, especially after having children or as we get older. And the urologists that I work with are indignant about this. They firmly believe that it is not inevitable that women should experience lower urinary tract symptoms. And for those that do have these experiences, there are very effective treatments. And this slide is just meant to illustrate that these symptoms are prevalent across all age groups. While they are more common in older age groups, they exist in younger age groups as well. The clinical iceberg analogy is commonly used in medical circles and is particularly true in the context of bladder health. With very few exceptions, most urology research is done in clinical populations. So these are individuals who often have severe symptoms who come and present for treatment. So they're the ones represented as being above the water here. One notable exception in research is the Boston Area Community Health Survey. And that study was a community-based survey that found 20% of women 30 years and older are experiencing moderate to severe lower urinary tract symptoms. And that overall 73% of community-dwelling women report having at least one symptom. In other words, there is a very large proportion of LUTs among women that's unreported or otherwise is hidden from view. And this could be due to a sense of embarrassment or stigma, a lack of knowledge on the part of women or providers. For example, very few primary care providers will ask the right questions or think to ask these questions, or the misconception that these symptoms are just a normal part of being female or aging. Over the last several decades, there's been a proliferation in the United States, at least, of advertising campaigns for products that are designed to help women manage symptoms like urinary incontinence through pharmaceuticals and incontinence aids. And while these advertisements for LUTs products could help reduce the stigma, they may also be serving to normalize the experience of having these symptoms. Although not necessarily life-threatening, lower urinary tract symptoms have a huge impact. Overactive bladder alone costs an estimated $66 billion in direct and indirect medical costs, as well as has implications for lost wages and productivity. This study cited at the bottom had projected costs associated with LUTs to be $82.6 billion in the United States by 2020. And then, of course, there are a lot of intangible costs that include people's experiences of pain and suffering and decreased quality of life. Substantial investments have been made in research to diagnose and treat conditions associated with lower urinary tract symptoms. For example, there are over 20 medications for management of overactive bladder. And historically, there have been over 200 different surgical procedures for stress urinary incontinence. There's a growing body of evidence that link lower urinary tract symptoms with other medical conditions. So women with LUTs have decreased physical and mental health, as well as are at increased risk for diabetes, cardiovascular conditions, falls and fractures, etc. Lower urinary tract symptoms have been shown to independently predict increased emergency department visits, even when controlling for comorbidities, age, and race. And the clinicians that I work with will routinely tell stories about patients, and these are urologists, so they're asking the right questions. They'll ask, have you ever experienced leaking? And they'll be told, no, I don't have any leaking. I mean, I did have it once, but then I stopped exercising, so it wasn't a problem anymore. And this is just to say that there's a lot of self-management, right, that's happening and modifying of social interactions to prevent the symptoms from occurring. It doesn't mean that someone didn't experience them or might not experience them otherwise. Therefore, I think it's really important that bladder health not be considered in isolation from a person's general health status and environment. And in fact, activities that can prevent and reduce lifestyle risk factors for chronic disease also may impact bladder function. So despite the high prevalence and societal cost, most research on lower urinary tract symptoms in women to date has focused on prevalence or on treatment, whereas considerably less has focused on risk factors and prevention. And this slide is just meant to highlight the opportunities that exist by shifting to a bladder health promotion and LETS prevention strategy. Which brings me to the PLUS Research Consortium. So recognizing there was a need for this shift, this consortium represents the National Institutes of Health's research emphasis change from treatment to prevention among girls and women specifically. And so these institutes listed here funded a multi-center transdisciplinary consortium over the past 10 years in an attempt to do this. There were 8 sites funded across 2 cycles, and then 1 data coordinating center, which was based at the University of Minnesota. 53 individual investigators were involved, and this slide is just meant to show the diversity of disciplines that were represented by the PLUS investigators. It was truly a team science transdisciplinary initiative. I also wanted to note that community engagement in all phases of the research was fundamental to the PLUS Consortium and our research efforts. This was actually my entry point into getting involved in the consortium. My research career has been heavily focused on sexual and reproductive health outcomes and more broadly maternal and child health. I had no prior experience with urologic health specifically, but I did bring to the table extensive expertise in community engagement and mixed methods. And together with several other investigators involved in the consortium who worked through that lens, we did a lot of internal training for other PLUS investigators about why this would be so important to include community partners and community members, and then built the infrastructure that you see here with the intention of conducting responsive research with rigor and integrity that would be able to maximize our research impact and develop the highest possible quality evidence grounded in lived experiences. And we had 2 main community entities, an adult group that comprised our Community Partnership Council, and then a group of youth members of our Young Women's Health Council. And then at various times would also solicit input and feedback from what we called our rapid assessment partners. So for example, when we were working through our survey measurement items, we had a core team that was working with other individuals beyond even those on our Community Partnership Council and Young Women's Health Council to get to strengthen those measures. Our main goals were to develop an evidence base for normal and healthy bladder function, identify and evaluate the relative importance of a broad array of risk and protective factors for LETS and bladder health, and then to ultimately develop and test evidence-based prevention interventions. Key features included this prevention science approach and a life course developmental perspective. So as I mentioned, this is not, bladder health concerns are not limited to just older age groups. We're very interested in looking at this across the life course, particularly in regard to risk and protective factors. There was also a very explicit focus, as shown in the 4th bullet point here, on girls and women. Women are at greater risk of experiencing lower urinary tract symptoms than men. They're 2 to 3 times more likely to experience urinary incontinence and 4 times more likely to experience a urinary tract infection than men. Part of their higher risk is due to anatomy and physiology, of the female urogenital system. And then women's hormonal milieu, experiences during childbirth and pregnancy, and gendered societal experiences may also be contributing factors. Here is just to outline our process for developing this new field of science focused on bladder health more broadly than just thinking about lower urinary tract symptoms. And I'll describe our process starting with just how we conceptualize bladder health in the first place, to administering tools that were developed through a national longitudinal survey. Bladder health in women and girls is poorly understood, in part due to the absence, or there was an absence, of a definition for clinical or research purposes. So a really important first step of our consortium was to come up with a working definition for bladder health. Historically, bladder health has been framed in terms of the absence of lower urinary tract symptoms. As you can see, our consortium definition of optimal bladder health parallels the World Health Organization definition of health by extending beyond just the mere lack of symptoms to also include concepts of well-being and resilience to short-term challenges. Another important landmark for the consortium was the development of a conceptual framework that encompasses all facets of social ecology. We wanted to integrate biology with social ecology and, of course, emphasize that life course perspective. And while socioecologic models are not new to those of us in public health, there were many members of our consortium, other investigators, for whom this represented an entirely new way of conceptualizing research questions. Similar to how we had to do training around community engagement, we spent a lot of time as a consortium thinking through ecology of potential risk and protective factors are for bladder health. Even for myself, I think about the socioecologic model all the time, but I haven't thought about, for example, the fact that we spend so much time in institutional settings, particularly schools and workplace, and the implications that those policies and practices that are in place in those environments might be impacting something like bladder health, or laws or building codes. That just wasn't in my purview. We even had an architect in the group who would talk to us a lot about the way building codes are set up and thinking about public spaces. So looking at this framework, I wanted just to operationalize it for you. So here is an example as it pertains to urinary tract infections. As you can see, there are things that probably come to mind at an individual level in terms of one's bathroom habits or hygiene practices, fluid intake, interpersonal factors with regard to provider and patient communication or sexual practices. I mentioned the institutional policies and norms that might influence one's bathroom autonomy or even fluid consumption, right, in schools and workplaces. We have community norms and public health, public restroom infrastructure. And then even at the societal level, for example, with UTIs, there are policies in place governing bacterial exposure and food and antibiotic use, and a lot of policies governing public restrooms, ongoing debates, for example, in the United States about transgender access. This conceptual model was integral in helping us identify relevant levels, right, of the social ecology and biology, and then to begin to generate a list of potential risk and protective factors at each level. And through literature reviews, examining theories of health and human behavior, clinical and professional observation, a focus group study that I'll discuss, we came up with 600 potential factors that might influence an individual's bladder health. And then went through a process of prioritizing these and then organized them into research themes. And this is all work happening in the first 3 years. This took time. This took a lot of time to do. And there's not a lot of need to spend time on this slide, but I included it because this was actually the point at which, driven by a small but very vocal group of investigators, sites began to also go through that community engagement process. We said, we really need the community perspective, and we're going to start to prioritize what we're going to look at and what might be the most important risk and protective factors to consider. Our ranking criteria are included on the left here, including things like the potential impact of public health or potential for intervention and modifiability. The exercise was challenging because we had these 600 factors, So we started to organize them into buckets, right, or constellations of risk and protective factors. We came up with 44 that included still over 400 factors, and then went through a process of trying to rank them by level of importance according to the criteria. And then, also acknowledged at this point that they could be grouped further. And so ultimately, the priority factors were categorized into these 8 themes. And we formed theme teams of investigators who were asked to develop specific research questions within their theme that considered all those different levels, right, of ecology. And we came up with 28 working research questions. I won't go through them all, but you can get a sense here. The themes are on the far left of what some of them look like. So 28 research questions across levels of ecology pertaining to bladder health that we thought would be important to think about and to potentially address as a consortium. And the ones in bold are highlighted as being some of the highest ranked priority ones. And here are some more as well. So not just thinking about prevalence, but really thinking about what might be happening across the life course, impacting women and girls' risk. While all this work was going on, we also launched our study of habits, attitudes, realities, and experiences, what we call the SHARE study. This was intended to explore adolescent and adult women's experiences, perceptions, beliefs, knowledge, and behaviors related to bladder health and function across the life course. We conducted 44 focus groups with 360 participants ranging from 11 to 93 years old. We grouped participants by age category so that we had our youth participants, especially the younger age groups, in the same focus groups with one another, and then older age groups in focus groups with one another. And you can see the categories here. And purposely tried to recruit a sample that was racially, geographically, and culturally diverse. We included Spanish speakers. 6 of the 44 focus groups were actually conducted in Spanish. All the data were translated and transcribed verbatim. These were some of the concepts that were explored, and I just use this to illustrate, again, our use of our conceptual framework and the multi-level, our interest in multi-level factors. So you can see, have you heard of bladder health and where it is? And that's, really reaching, getting at individual and level factors. But then we ask questions about, where do your ideas come from about your bladder, and where did you learn, about the habits that you use? And that gets, of course, more into the interpersonal domain, or there may be, rules organizationally that are coming into play. We asked about knowledge acquisition, lower urinary tract symptoms and care seeking, terminology people use, and importantly, public health messaging that may be received or may be desired. Our analysis approach was a multi-level content analysis that we used to classify emergent themes. We created a code book that included a priori codes aligned with the conceptual framework, but also allowed for inductive codes to emerge through our memorizing process and transcripts. We then also used a member checking and validation process whereby we tested the themes that were emerging in further group sessions with community members that included some of the research participants who had some of the people who had participated in the focus groups themselves. This is the distribution across different age groups. We had intentionally recruited more people from older age groups. And this is just to show that we were very successful in recruiting a diversity of girls and women in terms of age and ethnicity. While the predominant geographic region represented is urban, we did have representation from some rural areas, especially in the college age and older age groups. We did not recruit specifically asking people about whether they had experienced any lower urinary tract symptoms, but we did collect the data at the end of focus group sessions just to be able to better understand women's lived experiences with regard to bladder health. So this shows the distribution of our focus group participants' experiences with various symptoms. So some of them did experience symptoms, especially in the older age groups. And actually, even in younger age groups, we had about 44%, right, that are listed here. All right, so 5 topic areas were prioritized for the first phase of the focus group interpretation. They're listed on this slide. And we learned that when describing bladder health, women frequently rely on lay language as opposed to medical terminology and had a lot of informal knowledge. Many lacked accurate understanding of what constitutes normal bladder function. Normal, if you will, was often defined in contrast to incontinence. So you had normal bladder function if you were not experiencing any leaking, rather than a more holistic conceptualization of bladder health. Women often normalize symptoms as being inevitable, a function of aging, part of being pregnant, those kinds of things. And we did hear a lot about adaptive behaviors that were being used rather than seeking care, especially for chronic and gradually worsening symptoms. And common adaptive behaviors that came up were things like delaying voiding, delaying going to the bathroom, or precautionary voiding, doing, the just in case, doing before you leave the house, just in case, even if you don't have to go. Using pads, restricting fluids, a phenomenon we call bathroom mapping, where you're planning your routes and your outings around known places where you will be able to access a toilet. And we found adolescents held many of the same misconceptions as adults, often inheriting myths that they perceived from family and peers and school routines. And we felt this really highlighted an opportunity for intervention. Women across all ages describe daily negotiations around toilet access, safety, cleanliness, time pressure, and other social norms. School bathrooms are often perceived as unsafe, dirty, or monitored by gatekeeping adults. This would drive strategies then, like not going, delaying, avoiding the bathroom altogether, or limiting fluid intake. Similarly, in workplaces, we saw women described patterns of production pressure, having a lack of coverage, someone to stand in just so they could leave for a minute, and even punitive cultures around taking bathroom breaks. And this was particularly evident among individuals who worked in service, education, and healthcare fields. Public spaces, malls, shopping areas, parks, transit hubs are also experienced through the lens of safety, privacy, and cleanliness. And across all settings, our focus group findings highlighted how macro level policies, school rules, workplace policies, building designs can translate into micro level decisions about where and when to void. And then the data revealed rich social processes, this perception of being monitored by others and gatekeepers, and also monitoring others for what might be normal, stigma, embarrassment, bathroom etiquette, peer modeling, all things that are influencing people's toileting behaviors and self-care strategies. Finally, the data suggested there's a really strong demand for public health messaging about bladder health, and that experiences of the discussions that have taken place in people's lives are very limited in this regard. Often it's, when you have children, then you're going through a toilet training process, or sometimes when you're pregnant, you might talk to your provider if you're experiencing symptoms at that point. But it wasn't a common part of health curriculums, and it wasn't a common part of other healthcare interactions. And I'm fascinated by this and excited, because I think there are real opportunities with sexual and reproductive health and menstrual health and bladder health not to be so siloed, right, in our curriculums, and to think about more integrated strategies that we can be talking about these issues. And of course, participants expressed a preference for inclusive, culturally sensitive messaging, but they have that in multiple channels and formats: healthcare settings, schools, social media, community spaces. So the focus group data, along with all of the extensive literature reviews that we did, so the focus group data were interesting in and of themselves, and we published numerous papers on our findings there, but they were also intended to help inform the development of an instrument that we could have a more comprehensive measure of bladder health components. Most instruments just assume someone's also has ongoing and continuous symptoms, right, at all times. And we were looking for approaches that would additionally capture less frequent episodic or transient symptoms over longer periods of times. And so our next step was to start to develop a series of questions, survey items that we could ask related to bladder health that would more comprehensively assess this phenomena. We performed a review of all kinds of scales that existed in quality of life measures. These were evaluated for applicability across the full bladder health spectrum. When we noted gaps, particularly gaps that we learned from our focus group data, new items were then developed. And we went through a process of then cognitive evaluation and testing the questions to see if they were, if people understood the questions that we were asking, if it was capturing our intended construct, if people had difficulties formulating any of the responses. And we tested items in 2 big categories. We had our function-specific questions and our non-function specific questions. We had 167 women participate in individual interviews about the questions, and then another almost 800 who did an online panel survey. And some of the key findings from this process included that a lot of existing measures for lower urinary tract symptoms, since that's what most of them were about, required revised language, timeframes, and response categories to better capture the full range of bladder health. The term bladder health was unfamiliar, as had been evidence in the focus groups as well, and typically understood as an absence of symptoms or infection or cancer. Women did emphasize coping mechanisms and self-management strategies as central to their experiences and definitions for bladder health. And we did find that we needed to add prompts and response options for infrequent symptoms in order to lead to higher endorsement across the different bladder function components. Having gone through this process, we then did a validation study. So here we were looking to establish the internal and external validity of the new instruments that we had developed for population-based research, clinical research, and postpartum populations. As part of this process, again, the goal is to get the full continuum and not have these binary metrics that are just the absence or presence of symptoms. And we compared our responses as part of this process to the results of in-person physical exams as well. So that was part of the validity check. It was a cross-sectional study. We recruited a probability sample that was then supplemented with other more women who were living around our clinical centers. At the time, we had 7, because we needed that in-person component, people to be able to come into the center for their physical evaluation. Ended up with about 1,000 individuals. And this just gives you a sense of how we were looking at external constructs and internal dimensions of validity. The take home from this is that we developed a whole series of bladder health scales and bladder function indices and questions related to adaptive and coping behaviors in both electronic and paper formats. And so for the bladder health scales, there were a number of domains, including people's perceived efficacy, the potential societal and occupational impacts, physical activity impacts, emotional impacts. Each of these has items associated with it, and all of these can be summed into a global perception of bladder health item. And then we had bladder function indices, and these were more focused on the symptoms, right? The presence, the frequency of which someone might be needing to avoid. So getting at overactive bladder, sensation, continence concerns, comfort in terms of pain, and challenges with emptying. And all of these scales are on a 0 to 100 scale. This then all was in service of ultimately getting back to our original goals, to be able to determine the distribution of bladder health and bladder related challenges and knowledge in a general female population, not a clinic population presenting the symptoms. And also to identify factors that promote bladder health and prevent lower urinary tract symptoms in women. So we designed a population-based cohort study around our 8 research centers, recruited adults who were born or identified as female. We had a random probability sampling based on a commercially available database. We collected data both by mail or electronic survey. Participants had a choice, so whatever format they were most comfortable with. We had a subset of individuals coming in for an in-person assessment that also included microbiome sampling. And our baseline assessments were conducted for about a year-long period in 22 and 2023. We have just finished our 1-year follow-up and are in the process of our 2nd year of follow-up data. This was our organizational structure for this study. And part of what I'm excited just to share is this transdisciplinary process, right, of how you can go about doing this. We had a protocol and we had our coordinating center based in Michigan. But then we had investigators across these 8 sites, 53 investigators at one point. And we all have different research interests and come with different orientations, and ended up sorting ourselves into these research themes, right? And we had developed our scales and our bladder indices, but we still needed questions to get at our stress and mental health, and to be able to better understand occupation and job demands and look at physical activity. And so groups of investigators worked together to comb the literature and identify survey metrics that we could use in this large cohort study. And you know, it was a process also involving community partners to get the wording right, to prioritize the questions, because it's always a balance when you're doing these surveys between how much information you can collect and the burden, right, on participants. And then we had ourselves also organized into different cores to support recruitment and retention efforts, for example, or we had a group that was very, you know, interested in these biospecimens that were being collected at some of the in-person visits. We had a group that was dedicated to just cultural review and adaptation, and they were the ones who worked to develop a Spanish version of the survey. So this work was done in English and in Spanish. This is an overview of our data collection and all of the metrics that were included in the surveys and the time points at which they were collected. It's a bit of a busy slide, but it's just to say that in addition to our bladder health scales and our bladder function indices, we asked a lot of questions about a lot of topics organized by those themes above. And I wanted to highlight just a few of them for you that were novel as part of what we called our Rise for Health study. So one of the novel measures that was also developed through our focus group data and a cognitive evaluation process and evaluation process is our bladder health knowledge, attitudes, and behaviors scale. So this gets at self-reported bladder knowledge and perceptions and people's attitudes about some of the myths, right, that people believe out there, you know, in relation to fluid intake. We were also very interested in people's attitudes about their sense of control, about being able to prevent something like a urinary tract infection or incontinence, and also their sense of control about whether these things could even be treated if you experience the symptoms. We're also very interested in what people believed about the impact of pregnancy and pelvic muscle exercises. And the little figure just shows the process we use to create the item bank and then validate these metrics. Another novel and understudied area that Rise for Health was assessing was around toileting behaviors in relation to one's occupation. So we had a lot of questions in that regard. We also were interested in musculoskeletal health, and so we had survey measures pertaining to the domains shown on the slide, and then also the subset who came in and were in person to be able to collect all of these types of measures listed here. And then again, physical activity, stress and brain health. With regard to UTIs, a novel aspect was looking at the urinary microbiome and taking those samples. We had a lot of information collected on people's adaptive and self-care practices and also hormonal exposures. Ultimately, we sent out 50,000 invitations, got about 3,400 responses. So low, but it was still a representative sample, and we were very happy to have such a large sample. About 3,000 were eligible for the final analyses. Notably, 17 were not assigned female at birth, and we had another about 300 who didn't complete the survey. Not being assigned female at birth, identifying as transgender, non-binary, or another category did not preclude people from participating in the study. And we actually had a whole separate set of focus groups with this population. We had a couple investigators who really drove that initiative and were like, you know, there's nothing out there on the things that other people who don't identify as female or necessarily identify as a woman are experiencing. And so we do have a whole separate group of folks interested in analyzing that data. The mean age was around 50 years. Most, like I said, were cisgendered women. A majority lived in urban areas. You can see the racial and ethnic breakdowns by BMI, and also by menopausal status. So I'll just give you a taste of what we've learned so far. This is ongoing work. We're in the process of analyzing baseline data, starting to incorporate some longitudinal analyses. But these are the bladder health scales. And so on this slide, you're looking at the distribution of bladder health among the full cohort of 3,000 women. And on the left side of this this slide, on the left side of the slide, you can see the scales as they're traditionally measured without taking any adaptive behaviors into account. And across all these unadjusted scales, you see, higher bladder health scores in general, and this suggests that people are functioning fairly well. On the right side, however, is a more nuanced story. Here we're adjusting for adaptive behavior. So these are things like if a woman reported limiting their fluids, preventive voiding, planning routes around bathroom access, avoiding activities like exercise. And when we start to account for these behaviors, the bladder health scores drop across every single domain. And sometimes they drop quite substantially. So for example, physical activity drops from a median of 95 down to 69, demonstrating that many women maintain their activity levels only by relying on these coping strategies. The takeaway here is that the unadjusted scales may be overestimating the true bladder health because they don't capture like that hidden work that women are doing to be able to manage their symptoms. And I think these adjusted scales give us a clearer view of bladder health as women actually experience it. It includes not just the symptoms, but all the social and behavioral strategies that are going on in order to manage them. This is the rest of the scales from the bladder health scales, and you can see that the same pattern here has emerged. On this slide, we're looking at the distribution of bladder function for the entire cohort. So the bladder scales focus on behaviors and coping and overall functioning. These indices that are shown here are intended to capture the physiological and symptom-specific components of bladder function. So, experiences of incontinence, for example. And a few patterns stand out here. You can see that the overall function index shows that many women fall into the moderate to high function range, right? They're doing pretty well. But there is still variation across the whole cohort. The UTI index is heavily skewed, right, towards the higher scores. And that makes sense. Nearly everyone didn't report having had a recent urinary tract infection. And these infections are relatively infrequent in population-based samples. Frequency, sensation, incontinence, you see medians in the low 60s, suggesting that although many women report good function, there is a meaningful proportion that are experiencing occasional high frequency discomfort or mild incontinence, and and so on. The take-home message here is just that bladder function among women in the United States is highly variable. And while many report good function in specific domains, others experience notable challenges, even in the absence of very obvious bladder disease. Here I wanted to show again how the scores change when we adjust for adaptive behaviors. And on the left is the same data. Those are the median scores that you just saw reflected in the figures for the full study population. Again, the unadjusted scores are consistently high. When you adjust them, all the median scores drop down, in some cases very dramatically. But what's interesting about this table is the right-hand side. So these were the 700 individuals in the sample who said that they had not experienced any recent lower urinary tract symptoms. And even in this group, so these are people who did not report experiencing symptoms, the adjusted scores still continue to drop as you look across. While most remain relatively high, the consistent downward shift tells us that women are using adaptive behaviors even when they appear asymptomatic by traditional clinical definitions. Likewise, here we're looking at those indices. So this is really getting at the physiologic experience, the symptoms themselves, with the full cohort, and then again with the individuals who reported not having lower urinary tract symptoms. And when we look at those who have no symptoms, the pattern, of course, shifts noticeably upward. Across all the indices, the medians are at 100. That's the highest score. That's like the best functioning in all of these things. And even the overall index rises to 93. And so this tells us that women who don't report symptoms do indeed have good bladder function according to our scale. So this is a nice way that we validated that. And bladder function, again, it's highly heterogeneous in the full population. But for those that don't report symptoms, function is uniformly strong. So what's going on with these adaptive behaviors, which I think is one of the most interesting findings here. And here you can see in the full population, these behaviors are extremely common. So these are just a subset of potential adaptive behaviors. But over, almost 70% of our population reported engaging in some of these in a recent period. And even among those, again, who don't have symptoms, more than a third reported using at least one of these adaptive behaviors. And so we really think that this supports bladder health as a concept, as a separate measure, and not just looking at symptoms, but looking at overall health. And that there's this potential existence of maybe a pre-LUTS state, like a pre-symptom state, or a subclinical bladder experiences and behaviors that could be going on. What was the overall prevalence in this population? We had 79% of our sample report experiencing at least one lower urinary tract symptom in the past week. 43 experienced mild to moderate, and 37 moderate to severe. This is consistent with what was shown in that older study, BAC community survey that I shared previously, which was in the low 70s. You can see the breakdown of those who report storage symptoms versus voiding and emptying versus any pain. Importantly, though, only 7% had reported treatment, and these were mainly pertaining to, or reported receiving treatment for their symptoms, and this was mainly for urgency and incontinence. And this slide shows some emerging data that we're looking at, that is the extent to which having an experience of symptoms, being bothered by those symptoms, and talking to someone about those symptoms intersects. And we noted that over a third of the participants in our sample said they were bothered by symptoms, by lower urinary tract symptoms, but far, far fewer actually talked to someone, and even fewer than that talked to a healthcare provider. So again, work in progress, but our conclusions coming out of this Rise for Health preliminary baseline data are that we are seeing a very broad spectrum of bladder health, ranging from poor to optimal among US women, that there is high utilization of adaptive and coping behaviors, even among people not symptoms. The higher scale scores and indice scores in those who don't have symptoms was of great interest. We think it supports the concept of bladder health and shifting our focus from just symptomology to also considering subclinical bladder experiences and behaviors. This is a novel population also that could be right for prevention. There's obviously a need for more prospective research to determine if suboptimal bladder health is in fact a risk factor for future LUTS. And given the large burden that we observed in our sample of symptoms, both prevention and treatment related interventions are warranted. Here I just summarized for you, I've thrown a lot out there, kind of the culmination of the work over the last 10 years, what happened in the first 5-year funding cycle versus what happened in the second, where we're headed in the future. We had 14 research protocols developed through this consortium, 65 peer-reviewed publications with dozens pending. All of our publications we're working to put into common language summaries for community distribution, and we've done about half of them so far. I won't go through all of these. This is just a taste of the types of publications that exist. I have had so much fun with this consortium, and that I didn't realize how many process papers one could write about, just our work and how we function, and all the systematic reviews and scoping reviews that needed to be done for us to identify measures and create these tools that we were using. And so we have a lot of data for available in the peer-reviewed literature on these things. For example, scoping review of quantitative assessments of bladder health knowledge, attitudes, and beliefs. Plus just the developed one, but there were other methods out there that we of course looked at too. One of the things that was exciting about this consortium is, that first 5 years, we didn't do any data collection except our focus group study and some of the validation work. But there were longitudinal studies that we were able to leverage and do analyses in service of our goals of understanding risk and protective factors. So the Avon longitudinal study on parents and children, the BAC study that I mentioned before, and LEARN, which I can't remember the acronym for, but there were a lot of studies that we were able to look at data for and start to do secondary analysis in an attempt to understand risk and protective factors so that were showcased in our conceptual model. Lots of data coming out of the focus group studies, publications on our validation process. We developed an app. I didn't even get into this, but we have an app that collects data in real time. And we did a pilot with women who would assess public restrooms or where they're going or when they're going or how they were feeling at the time. And so this is an entirely new arena for this type of research to be able to do that type of data collection. There's ongoing work to develop adolescent versions of all of these tools. And then these are the Rise for Health studies to date. So I gave you just the sampling of our preliminary data on prevalence rates and treatment and that kind of thing. But we're starting to look at things like associations between social identity, socioeconomic position, and women's bladder health. Toileting behaviors, is it better to sit or is it better to squat, or does it make a difference? We don't know. And so we're using this data to be able to ask those questions over time, ideally. And lots of questions for people interested in the musculoskeletal system, microbiome, and many, many more papers under development and plans moving forward. My concluding thoughts are just that through this initiative, through this transdisciplinary approach, we were able to develop conceptual models and paradigms, innovative measures, and establish foundational knowledge for future interventional research on bladder health and LITS prevention. And together, these efforts will pave the way to improve the quality of life of girls and women across the life course. This website has tons more information and links to all of the publications that have happened. These are members of our consortium, and I thank you. And I know we don't have tons of time, but I'm happy to answer questions and comments. And please reach out if you ever want to talk more.
Thank you very much, Shayna, for this rather overwhelming comprehensive presentation. But it's a very important topic, and I think I have lots of questions myself, but I have access to you otherwise. I would like to ask our participants, when I think about the strategies that you described in terms of navigating toilet access and toilet mapping and the padding and all the other strategies that women use on their own, access to toilets in many parts of the world is extremely limited. And I'm wondering what people think about how this kind of research, I mean, we're talking about an impact that is totally illustrative of the cost of not addressing other women's health issues besides reproductive care. This totally complements all that we've been talking about the McKinsey and World Economic Forum report last year. What do people think about this in terms of its application in global South settings?
Yeah, I was about to ask this. Thank you, Judy, for opening it up. Because, when she explained or when she described the navigating the toilet experience, and I could relate it to experiences in Pakistan. There are a lot of, studies related to that, that even women drop out from school because they do not find, suitable toilets, available in schools. Even workplaces, I've seen they have horrible toilets, for women. So I think, unfortunately, these issues have not been highlighted. I think these are public health issues. And I think even at the primary care level and at, family physicians, they should sort of promote this and, raise awareness of these issues, because these are very, very important and pertinent. And your research is very pertinent to, I think, to the global South. And it should be, I mean, I wish there could have been more people attending today, because the issues that you have raised are very, very important issues. Thank you, Shan.
I'd like to invite other people to comment or ask questions. I know we have many.
Yes,
Go ahead.
this is Godwin. Thank you for the insightful presentation, quite lucid. Thank you very much. I couldn't read the publications, but most of the ones I saw relate to studies that tended to identify all the factors. But I was just wondering if you have interventions that actually targeted policymakers, because I remember you used the socio-ecological model, which is great. But at the policy level, have you been able to carry out any intervention in that direction?
It's an excellent question, and all of this work is intended to be in service of this of intervention development, not just educational campaigns and working with providers, but also specifically at the policy level. And we have not done that yet. I was one of the facilitators for a Young Women's Health Council, and I will say that as we've engaged in conversations with youth, around even before, honestly, we had the data and started to analyze the data, they were taking even just these conversations back to their schools and trying to have discussions with administrators in those contexts, and thinking about school policies that were maybe restricting bathroom access for students. And so it's not what you're describing, which is a much more high level policy workplace public access kind of thing. And I think our hope is that this evidence base that we're generating is going to help drive that agenda. And that is the next phase of the work, is to take what we're learning and translate it into better programs, policies, and practices. But I will say anecdotally, particularly with the community members who've been engaged, even without the data, they were excited to talk about these issues and bring these issues back to their workplaces and their schools, and see what changes might be able to benefit students and employees in those contexts.
Thank you very much.
Other comments or questions?
I will say this work was fun to do. The focus groups in particular, it was almost cathartic for women to talk about. And they would laugh, and then they'd say, "Don't make me laugh, you'll make me pee." Like they were lively and engaged, and the types of scenarios that people say afterwards, "Thank you, I just have never had an opportunity to talk about this before, and I hadn't thought about it," and in a lot of cases hadn't thought about it before. And I was certainly someone who was guilty of the, well, if I'm not thinking about my bladder, it must be healthy approach to defining bladder health before becoming involved in this work. And I hope that there are opportunities to expand. We have many tools now to share and to use, and protocols in place. So if there are people at any point interested, please send them my way. And if I am not able to help them, I will refer them to other investigators who are part of our consortium, because ideally all this work, we'd like it to continue to be used and to continue to help inform.
Well, and I think you created a safe environment for a sensitive conversation. I mean, as your diagram showed, women do not share this information with people. And so the fact that happened, but it also suggests there's a larger issue in terms of stigma about talking about these basic bodily functions. And I mean, I want to say I had to take a urine sample to a lab yesterday. And I walked out of the house with it in its little clear plastic bag. And then I realized, oh my God, somebody might be offended by seeing a urine sample. So I put it in the shopping bag to take it into the lab. I mean, that's how ridiculous it is. So I think you're addressing, I think the beautiful thing about this is the layers of the model, and going from the bionome through the medical conditions, through the whole socioeconomic ecological model being addressed in such a comprehensive way. But it also took a lot of resources and a lot of time. And if we apply this kind of investment in other women's health, and I'm going to say conditions, because these are not necessarily diseases, we would be in a much better place as a world that we live in. So I want to thank you very much for bringing this topic to attention, and I hope it increases awareness of all of us in terms of working with our women's health issues, that it's a much more comprehensive approach that we need to be taking. Thank you.
Yeah.
Thank you.
Thank you.
For the opportunity.
Thank you, Shayna. Thank you so much. I would also like to ask the participants to please go to the chat. There is a form, feedback form, please fill the form and give your comments, and as well as you'll receive a certificate, also webinar on filling the form. Okay, thank you, Shayna, so much from all of us, from WHTF board members and members, and we look forward to hearing more on your success with this, with these evidence. Okay,
Thank
shall
you.
we, Judy, is it ready to ready to close the?
Yes, yeah. Thank
Okay,
you all for
okay.
attending.
Thank
Thank
you.
you.
Thank you. I hope you feel